Thank you, Chitra. The topic given to me is flap lift or PRK as a treatment modality for enhancements. These are my financial disclosures. I'm a speaker and travel support for these companies of no relevance to the topic under discussion. Before we go on to how to do enhancement, let's understand the controversies involved in enhancement per se. Do not treat if the patient is happy. When Tenzing Norgay was asked, why do you climb mountains? He said, because it's there. The same logic does not apply to residual refractive errors. Oftentimes I come across patients who are perfectly happy with their refractive outcomes. They come 7 years after their primary surgery. The enthusiastic young optometrist lets them know that he or she has a minus 0.75 residual in one of the eyes. The person comes into my cabin looking quite upset about the whole thing, and that's the first time they've come across. So do not create a problem where one doesn't exist. We really tell our optometrists, if the patients are quite happy, don't be so persuasive about making them read the very last line. Practically, if the patients are quite happy with what has been achieved, then you leave well-be alone. Pursuit of perfection is often accompanied by risk, and as you will see, enhancement, though is very much possible, is definitely has a certain amount of risk. Having said that, my tendency to enhance has also come down quite drastically. Whenever we come across a patient who is unhappy, even with a 0.5 or 0.75 diopters, we go ahead and enhance these patients, because once you get an absolute correct refractive outcome, these patients are so much more happier. But when this patient presents to you, do make sure that you rule out keratoconus, iatrogenic keratoectasia, because one of the common ways that it presents with is a recurrence of the power. It might be an irregular astigmatism, it might be just some of the minus power coming back. An early cataract, nuclear sclerosis, LASIK done about at the age of 30, 35 for a high power. 42, the patient has an onset of cataract, and it might be the nuclear sclerosis which is causing residual refractive error. Obviously, you would not like to handle it on the cornea. Macular degeneration causing a drop in visual acuity. Obviously, it's not the refractive error which needs to be touched upon. I think monovision is God's gift to humankind. And if there is a patient who has been treated at the age of 35 and comes back with a residual of 42 of minus 0.75 or minus 1 in one eye, I think you couldn't have done better than that. Please do not touch these patients. Even if they are past 35, if you have a small minus power, residual power, take time out to explain to them that having that small minus power is good for them, and in the end they would be much happier with that. And whenever these patients come before doing the enhancement, make sure with the refractive error that you are going to correct, the patient is going to achieve excellent visual acuity. So they expect normal best corrected visual acuity before enhancing these patients. What are the prerequisites? Whenever a patient presents to me for enhancement, I make sure that we examine these patients 3 months, if possible 6 months apart, to ensure there is a stable refraction, stable topography. Sometimes you have a residual refractive error at the end of 3 months, and if it's not stable, do not go ahead and enhance those patients so early. It's extremely important, even if the primary refractive surgery has been done elsewhere, that you exert every effort to get what exactly was done in the primary refractive surgery, what was the power that was corrected, what was the corneal status, what was the corneal thickness. Obviously, if when a 520 microns minus 12 diopters had been corrected, I would not enhance for a minus 1 diopter 1.5. But it was a 540 microns with minus 2 as a residual error, and 0.75 was minus 2 was a primary refractive error, and 0.75 is what is residual, then obviously I'd go ahead and enhance. Ensure that at the end of your enhancement, you leave behind a pachymetry of at least 450 microns, and residual bed thickness should be at least 300 microns once you enhance these patients. As far as another aspect is concerned, especially when you have small refractive errors, just taking care of the ocular surface often resolves the complaints that the patient has. Adequately addressing dry eye, meibomian gland disease, optimizing the ocular surface, even if it takes time. Usually what I do is when the patient has a residual refractive error, I call them back for 3 months, 4 months later for a checkup where I make sure that the power as well as the topography is stable. In between, put them on adequate amount of, even if there is no obvious evidence of dry eye, put them on adequate adequate amount of lubricants, and also enhance their ocular surface. I do believe that many of these patients do not require an enhancement per se. What exactly the choices that we have? We can recut and make a new flap. Actually, 17 years back when we started doing LASIK treatment, that was primarily the way we were doing enhancement. We can relift the original flap. You can do a surface ablation. These are the two primary aspects that I will be dealing with. And there are two other incidental procedures that I come up with, which we'll see very briefly. As far as recutting the flap is concerned, if you have primarily done a 100 or 120 micron flap, you could go ahead with a 140, 160 micron, and especially if there is adequate amount of corneal tissue that's there, and cut this flap. But then many of these patients have earlier been done by microkeratome. You're not sure about the primary thickness of the flap, and in these situations, going ahead and recutting the flap might be quite erroneous, and you could end up with silvers of tissue, which even though may not be in the visual axis, can cause significant irregular astigmatism. Two other aspects have been talked about where you use a femtosecond laser essentially to create a sort of a gutter which is inside the primary gutter that is there, and then you relift the flap. And there is also another procedure where you essentially not only use a femtosecond, if the primary flap is 120 microns, go ahead and introduce 100 microns, and parallel to that, create an entire flap and relift it. This you do only if you do want to give more work to your femtosecond. I do not believe that these are procedures which are of choice. It's relifting the flap even 12, 13 years, 15 years later, we have found is not really a challenge. As far as you employ the right techniques, you are able to identify the peripheral gutter. Sometimes just gently pressing on the central area brings into prominence the peripheral gutter, and then introducing the blunt spatula and relifting the flap is no challenge. If you have a femtosecond laser as the primary procedure, then there is stronger wound healing at the flap margin as well as the interface, and especially with the earlier femtosecond lasers where more energy, inflammation and healing used to happen, these additions of this flap is much stronger, and then it becomes a little bit more of a challenge to relift these flaps. Compare these two videos where you see a microkeratome flap being lifted up 8 years subsequent to the primary surgery and a femtosecond flap being lifted up just 9 months later. You can see it's doable. It's possible to relift a flap which has been created by femtosecond, but it definitely is more challenging. But that gives you also the safety factor that these flaps have a lesser propensity to displace, and that I think is one of the primary advantages of a femtosecond created flap. If the primary procedure has been done elsewhere, there is a patient, a doctor who was being operated in Calcutta, underwent an intraocular lens implantation, had a significant residual error. I'm relifting this flap almost 10 years after his primary surgery. Usually all my flaps are made with a superior hinge. The hinge is over here. But in this patient, I have no data about his primary surgery, and I'm not sure where exactly is the hinge. And that's the reason I'm proceeding very tentatively. I could not see any kind of line. And you see that I'm trying to open up over there, but I find that it's not giving way over there. And surprisingly, it gave way superiorly. So it's again a challenge over here, but then it's you can see that I'm lifting. This is a nasal hinge flap, which is essentially something that I hardly ever do. But you can see that with patience and perseverance, you can lift even these flaps. So what exactly are the problems with the flap lift? Essentially, especially if it's a late flap lift and you have untidy epithelial edges, there's more chances of epithelial ingrowth, which can be, various studies have shown, it can be from 2 to 43%. So avoid excessive maneuvering, be as gentle as possible. Older the patient, more chances, hyperopic corrections, and especially if the epithelial abnormalities, there are more tendency for a flap, for epithelial ingrowth. These are some of our own cases. Mind you, these are not, all of them are not enhancement cases, but it's just to tell you that epithelial ingrowth does occur, can occur, and especially the incidence is significantly more if it is relift, and that's one of the reasons you are looking at alternative modalities. Even if it's peripheral epithelial ingrowth, if it's causing a significant irregular astigmatism that causes a significant drop in the quality of vision these patients have. But if you have an epithelial ingrowth, it's not the end of the world. You can see here a patient with a central epithelial ingrowth, and over here a patient with just in the this is central, and what you see in the lower end. And basically what you do is to just lift up these flaps and gently scrape off that ingrowth that is over there. Just lift up the flap to the extent that is necessary. Place a mitomycin C. 0.02%. Usually we place it for 30 seconds for all of our surface ablations, but in this situation I place it for a period of 1 minute, and usually you find that the epithelial ingrowth is handled quite adequately with this, and no further procedure is needed. Occasionally suturing of these flaps at the ends, etc., is necessary. So this is essentially this epithelial ingrowth, because of which we are somewhat going slow on our relifting these flaps, and today we are looking at PRK over the flap. I believe that this works extremely well, and today this is the procedure of choice for me as far as enhancing small amounts of refractive error is concerned, and that's usually what you face. It's what you do is a PTK mode. Go ahead and do a transepithelial PRK, remove the epithelium with 50 to 60 microns. What you saw was the epithelium being removed, and subsequently go ahead and treat whatever the refractive error that's there. Place the mitomycin C. In these cases, I place for a period of 1 minute, 0.02% again, and then go ahead and place a contact lens in the eye, and you would find that nearly a week later these patients are doing extremely well. So basically, I believe that within 3 years of primary LASIK, if you do a flap lift, there's greater chances of one epithelial ingrowth, less chance of epithelial ingrowth, but it is after 3 years, there's almost a 7% chances. So if it's a late, the patient is presenting to us quite late, after the primary procedure is done, I have a greater tendency to go ahead and handle the procedure on the surface. PRK on flap has its own shortcomings, in the sense that you can have pain and discomfort, slow visual recovery, haze, and prolonged medication. All of us are aware of these limitations of PRK. And once epithelium is removed, you can see this under flap striae, and this is something that I already dealt with. And Chitra already showed you several cases of topo-guided ablation. Whenever you have to do a topo-guided ablation, it's on the surface. You do not lift up the flap, but just do it on the surface. So essentially we have two alternatives, flap lift and laser on the bed, or PRK over the flap. And PRK over the flap may be a safer option, though lifting up the flaps is also a consideration that you can always keep in mind. Thank you so much for your kind attention.